We are back on the set of The Fast and Ferocious, and oh my god, we get to meet Van Petrel! While we wait for him to make his appearance, let's check in on some of these stunts. This hill is shaped like a long urethra, to remind you that urethral injuries almost always happen in patients with long urethras, meaning patients with penile urethras, and it's cracked to symbolize an injury. Here come the motorcycles. Motor tricycles? Trying something new for this installment, eh? Works for me, since their rather phallic shape serves to illustrate the signs of a urethral injury. This red mud at the front of the cycle, where the urethral meatus is, serves as a reminder that blood at the meatus is an important sign of urethral injury. The mud on the back two wheels should remind you that scrotal or perineal hematomas are another sign, since the wheels are like the testes. Finally, see how high that pro is riding, and on a state brand tricycle? He should remind you that a high riding prostate on rectal exam is another finding associated with urethral injury. You're more likely to see certain physical findings depending on the mechanisms of injury. For example, anterior urethral injuries are more common in saddle or straddle type injuries, hence the broken saddle and anterior position of this crashed cycle. And thus, patients with saddle type injuries are more likely to exhibit a scrotal hematoma than a high-riding prostate. Posterior urethral injuries, on the other hand, are more commonly associated with pelvic fractures, since the fractures themselves are closer to the posterior segment of the urethra, shown by this stunt person thrown behind their cycle, with their motion capture balls all fractured. In contrast to saddle injuries, these are more associated with high-riding prostate than a scrotal hematoma. If a urethral injury is suspected, a Foley catheter should not be placed. We repeat, a Foley catheter should not be placed. Instead, a retrograde urethrogram, also called a RUG for short, should be performed first to look for the injury. In this study, contrast is flushed up the urethra and imaged with an X-ray or fluoroscopy. An injury will be seen as contrast leaking from the urethra, just like this oil is leaking out of the tube here. Or oil hose, or what even are those called? The point is, it's leaking. In a full urethral injury, where the urethra is completely transected, as opposed to a partial injury, contrast will not be seen entering the bladder. As we just said, a suspected or confirmed urethral injury is a relative contraindication to Foley catheter placement. So, just look at our recurring symbol for a Foley, the Foley straw. See the balloon on the tip? And to remember that it's contraindicated, the martini is crossed out. No drinking on set. Management for urethral injuries depends on the severity, with different strategies for partial or full tears. Full tears typically require surgical repair with urinary diversion, just like this traffic diversion sign is implying, with either Foley or suprapubic tube placement. Partial tears may heal with just a Foley, placed by a specialist so as not to make the injury any worse. And that does it for urethral injuries, but we're not done with this sketch, since just upstream from the urethra, the bladder is also associated with pelvic injuries. So, our director is bursting his bladder-shaped glass. I guess the stunt did not go as he wanted to. The red juice he's drinking is red to remind you that frank hematuria after Foley placement is a common sign of bladder injury, along with suprapubic pain and difficulty voiding. See how the dispenser inside the jug is shaped like a Foley balloon? All suspected bladder injuries should be confirmed with imaging. The first choice is a retrograde cystogram, similar to the retrograde urethrogram we mentioned earlier, except here we'd see contrast leaking from the bladder itself, just like the black oil here is leaking from the tank this time, not the hose. Imaging will also reveal whether the injury is intraperitoneal or extraperitoneal. Intraperitoneal bladder ruptures are most often caused by blunt trauma to the pelvis, as increased pressure in the bladder causes it to pop at the dome, which is the bladder's weakest wall, just like we've put this hole in the dome of the tent as a reminder. Since the dome is covered in peritoneum, when it ruptures, the urine enters the peritoneal cavity. Urine is extremely irritating to the peritoneum and causes an immediate chemical peritonitis with associated peritoneal signs. Fast exam would also be positive, since the urine in the peritoneal cavity reads as positive intraperitoneal fluid, making this challenging to diagnose on fast alone. The bladder injury itself won't cause hemodynamic instability, which is why our tent security guard here is standing stable while holding a metal detector. But don't forget that other injuries can cause instability, which can cloud the clinical picture. This hole in our tent needs to be fixed. So, surgery is the treatment strategy for intraperitoneal injuries, just like our handyman is repairing this tent. A Foley is often left in place to decompress the bladder until it's healed all the way. Looking back outside the tent, let's finish up this take by talking about extraperitoneal bladder injuries, such as rupture. These most commonly happen from fragments of a fractured pelvis lacerating the bladder, most commonly the anterior wall. So we've added leaking urine around our fractured pelvis fellow from earlier. Extraperitoneal bladder ruptures are contained within the extraperitoneal tissue, and nothing enters the peritoneum. So fast is typically negative, hence our broken metal detector wand. Since extraperitoneal bladder ruptures are typically well contained by the surrounding tissues, the bladder will typically heal fine, back together again on its own, so long as the bladder doesn't keep filling up and stretching out the injury. So, to decompress the bladder and allow the bladder to heal by secondary intention, either a Foley catheter or suprapubic catheter is left in until the bladder is healed all the way. So, to remember that, we've added another juice dispenser with a Foley straw, but this time it's yellow, to show that the urine is back to normal yellow here. And this drink is also super tasty, to remind you of suprapubic. And see how it's almost gone? Like the bladder is decompressed? And that ends this scene on urethral and bladder injuries. So, before we roll on out of here, let's review. Urethral injuries are associated with pelvic trauma and present with blood at the meatus, a high-riding prostate, and/or a scrotal hematoma. Urethral injuries can either be anterior, which are associated with saddle-type injuries, or posterior, which are associated with pelvic fractures from fragments lacerating the urethra. Any suspected injury should not have a Foley placed until after a retrograde urethrogram is performed, on which an injury is seen as contrast leaking from the urethra. Treatment varies depending on the severity of the injury, with either surgical repair for a full injury or specialist Foley placement for a partial injury. Bladder injuries are also associated with pelvic trauma. Frank hematuria after Foley catheter placement, suprapubic pain, and an inability to void are all signs of bladder injury. Retrograde cystogram is best for diagnosis, and would show contrast leaking from the bladder and whether the injury is intraperitoneal or extraperitoneal. Intraperitoneal bladder ruptures are associated with blunt pelvic trauma, causing increased pressure that ruptures the dome of the bladder. These injuries may cause a positive fast despite no hemodynamic instability, chemical peritonitis, and require surgical repair. Extraperitoneal bladder ruptures are associated with laceration of the anterior bladder wall by pelvic fracture fragments, would have a negative fast, and are managed with bladder decompression with a Foley or suprapubic tube to allow for bladder healing. Now, I don't want to sound too cocky, but I think we nailed that sequel.